All right, guys. Well, it's just kicked over to 6:31. Thank you for giving up your evening to join us at our next grand round session. Tonight, we've got Dr. Lachlan Fieldhouse. He's our Director of Clinical Services from Tasmania. And he's going to be presenting on really just an update on medicinal cannabis in primary care. He's got about 12 months experience in prescribing medicinal cannabis to a number of patients. And he's just going to share what he's learned along the way and how it's evolving into the primary care space. So if you have any questions, pop them in the chat and we'll get to it as soon as practical. But look, I'll hand over to Lachlan to take us through an update on medicinal cannabis in primary care.
Thanks very much, Jared. And look, thanks also to other members of the Clinical Advisory Board for supporting GP to GP education. This is something I think that's interesting to hear from another peer in the space practicing in day-to-day clinical practice. I'm just going to share my screen, and so hopefully that pops up. And as with always, please use the chat function. These sessions are really helpful if they're interactive, and we can always pause and take some questions. What we're going to go through tonight is just a little bit of a touch around my experiences in medicinal cannabis prescribing in Tasmania. It's an area in Australia where it's been a bit late to the party. And I put a disclaimer up. I'm nowhere anywhere near an expert in medicinal cannabis prescribing. It's a very small part of what I do in my part-time clinical practice. And there is a lot to learn. And if you're interested in staying in touch, we'll hopefully be able to send some more resources around. But I wanted to keep this topic of conversation relatively superficial and giving you a sense of what's going on out there. I appreciate very few of you would be looking at starting up your own medicinal cannabis treatment for your own patients, but you will have some patients, no doubt, that are on this treatment, and how you monitor them, how you support them, how you talk to them about that treatment and how it's going amongst all their other often comorbidities. Hopefully there's some few things that are useful for you here tonight. So there's some learning objectives there that you've had in the invite as well, but just to remind you, we have this thing called the endocannabinoid system, and we'll learn a little bit about that just from the video in a minute, but I always like to weave a bit of art in with the medicine and science if we can, and that as Jim talks out nicely in the video, the endocannabinoid system in humans is a bit like the conductor of the orchestra. And in many ways, we've got this system within us that is, and it hasn't evolved with the cannabis plant. It's been around for tens of thousands, if not longer, millions of years in us for regulating some of the homeostatic functions. It just happens to be the cannabis plant that's been around for a lot less than that. It has a medicinal cannabis role in trying to help regulate this system that can come out of balance with certain conditions. And more commonly in certain people. So, without further ado, I'll introduce via a video of a colleague of mine, Jim Connell, about what the endocannabinoid system is.
Hey, Lachlan, we can't see that presentation or hear that.
Right.
You might have to share you might have to stop sharing that one and share the other one. Yeah, and then we've got no audio for that one.
No audio on that one.
No.
I think I can fix this.
So cannabinoids don't just come from the cannabis plant.
Is that better?
Yep, perfect.
Thanks.
So cannabinoids don't just come from the cannabis plant. Our bodies actually produce cannabinoids themselves. These cannabinoids are just our body actually put together. It's almost things.
Lachlan, it's a bit hard to hear that. Is there any way we can improve the audio?
Not sure. Trying to run out without having the speakers and the headphones. So it's not worth pursuing with.
No, it's too. Can't hear that.
Sorry about that. All right. We'll scrap the video.
That's all right. They've dropped the link into the thing for people to watch, so that's fine.
You got me back on the screen now.
We're just waiting for your screen to pop up.
Sorry about that. Failure 101 of presenting.
It's all right. You're back on the screen now.
What Jim was trying to say is that we can't measure the regularity or the tone, as sometimes is used, of the endocannabinoid system, because these small, very short-lived molecules are often synthesized and then utilized during a short hormonal transmission. So people have often said, is there a test to figure out how my endocannabinoid system is working? No, there's not. A lot of the inference we take about this being out of balance is about how disease processes can affect individuals. We see this with mental health disorders, we see it with pain in particular. So if you'd like to learn a little bit more, go and have a look at that video. But in effect, what we're trying to do is we're trying to use an external modulator to the body's endocannabinoid system in order to try and reduce some of the symptom burden of certain disease states and potentially actually try and address some of their underlying drivers. But again, the work in this space is evolving. As some of you might be aware, there's some work in psychedelics going on, psilocybin, MDMA, and LSD, around how they can be quite helpful for certain significant neurological and psychiatric disorders. And again, we're seeing cannabis has been around for a lot longer. So many of you will have heard of CBD1 and CBD2 receptors. These are a bit like the endogenous opioid receptors in our body, and that they're throughout our organs. And CBD1 and 2 are the main types that we classify, but there are a lot more. You can see the regionalisation there. CBD1 receptors tend to be in the central nervous system and 2 in the peripheries. Interestingly, in the spleen, there's quite a few you can see in this area here, but for reasons no one, I don't think, appreciates. So what we're talking about is often central actions that result from medicinal cannabis therapy. Often side effects rather than therapeutic effects are often through the CBD1 receptor. CBD1 receptor, sorry. So there's a relative or significant increase in prescriptions being prescribed here. You can see in January 2022, 220,000 prescriptions have been filled. That's a cumulative indice, which is about 1 prescription for every 100 humans alive in Australia right now. And you can see this is a significant growth area. And this is in Special Access Scheme B approvals. We'll talk about the different levels of authorisations you need for the TGA coming up. In another study here, this is an Australian context of 1,388 respondents over 2 years, so it's a moderate sample size. The percentage on the left relates to participants where they were able to report more than 1 symptom. So this is a self-reported symptom experience. So a lot of people had pain, anxiety, and sleep issues, which is why these numbers here on the left are not going to add up to 100%. Respondents reported using cannabis through this study on 15.8 days in the past 28, 71% through inhaled, 26% through oral mode of action, spending around $82 per week on average on the cannabis. So this was done in a non-prescription setting primarily, looking at what people themselves have been self-treating with in the Australian context. And there were high levels, as you can see there, of self-reported efficacy. There were also high rates of side effects, and I'll show you some information on that too, but much of the side effects of treatment are quite tolerable. Interestingly, it said there that few respondents, I think 2.7% in the study, have actually accessed it through legal means. So from this study here, you can see this is a table of some of the side effects that are being experienced. A third of people pretty much got dry mouth, and only 2.4% of that was actually severe and intolerable. But most people say, oh yes, something I've noticed and it's not a problem. And these are really important discussions to have with patients who might be considering treatment, and also important decisions around what sort of medicines you might be prescribing for patients who are already getting it from somewhere else. Interestingly, I draw your attention there that 5% of patients found increased appetite intolerable. Most people I find that feel a bit hungry with cannabis therapy usually don't report that as a problem. Can be though, if they tend to overeat with it, but again, not usually a subjective problem itself. And that just extends from that study again further. You can see a large range of side effects. Panic attacks, nausea, vomiting, and you can get some significant cannabis hyperemesis. One of the ones that's not actually listed there is one that's important, is testosterone deficiency. So for people who have been on long-term, particularly high dose cannabis therapy, there is a risk of testosterone deficiency too, as it affects the pituitary neurohormonal axis. But again, that's probably not something people would self-report. So look, the studies are numerous across the world. Again, not a lot in the Australian context because of it's recently only become available through prescription. And a couple of societies and groups in medicine have put forward some position statements. And I thought I might just share what some of those are. The International Society for the Study of Pain, which there is, I didn't realise that existed, so they exist, and they say, due to the lack of high-quality clinical evidence, the Society does not currently endorse the general use of cannabis and cannabinoids for pain relief. Don't generally endorse, fair enough. Royal Australian and New Zealand, or Royal Australian New Zealand College of Psychiatrists say the evidence for the use of medicinal cannabis in the treatment of mental disorders is very limited, and there is no substantial evidence to support its use outside of properly approved research trials for these disorders. And speaking with some psychiatrists, that is often their individual position as well, I find. And then there's our GP college statement, and this is a 2019 statement, so it's done some yards, and it says, the current available evidence does, however, suggest a possible role for medicinal cannabis products in a number of areas. Therefore, if after conventional evidence-based treatments have failed and the specialist general practitioner feels that medicinal cannabis products are a viable treatment option for their patients, they should, as other specialists can, be able to prescribe products in accordance with the current regulatory framework. So, it's not uncommon in medicine. We have differing views from different groups and different individuals, and I think that that's good. We need to look at all different options when people can have complex experiences. So, look, that's something I'd like you to think about during this presentation. Is there a role? What is that role? What's my role in patients experiencing cannabis treatment? How do we ensure that this is something that's safe and effective for our patients? And a big part of that's patient selection. So, often you'll get people coming up to you who might be using cannabis on what's called the green market, the illicit market, and sometimes they might ask for you to become involved in helping them. There's been a couple of patients I've had through that process. But just be really careful about those with a problematic history of substance use or a family history of addictive disorders. That can be a group that's very, very careful in selecting. Often people who have failed multiple conventional treatments, so you might have 3 or 4 different treatment options that have all failed. Maybe it's something to think about with them. And also patients where the quality of life factor needs to be considered. So end of life care, people with significant disability, and often people with intractable cancer pain. I've heard anecdotes through many patients that their family members have actually, through a death experience has been a trigger for them to want to talk about it with them. Particularly, I've had some success with patients with chronic opioid use anhedonia as well. So those that have been on the Oxycontin for 20 years and really just, lost all interest in the enjoyment of life and want to try and find a new way forward. But that's been very helpful for those people. Also chronic fatigue syndrome, where pain and insomnia are big drivers of the symptom burden, and an intractable treatment-resistant anxiety disorder as well. If you actually look at the TGA data, I believe that in Australia, across all prescriptions, I think 2/3 or so, a good majority, is for anxiety disorder. And also quite a few elderly patients with osteoarthritis-related chronic pain. I've had some significant benefits in that group too. Not a group that I would have thought might be interested in having these conversations. So just some terminologies there for you. And Jared, how are we going in the chat? I've lost the chat.
The chat, which was about whether, and I don't even know if you know the answer to this.
Pharmacy defense.
Yeah, do you know anything about the Pharmacy Defence Organisation and their position on medicinal cannabis?
I have never heard of the Pharmacy Defence Organisation.
Yeah, do you know if our medical defence organisations have a position on that? Do you need extra insurance? Is it considered within the scope of practice of general practice?
It is considered within your scope of general practice. But again, it sort of depends. It's a bit like using steroids, you could say. Using cannabis is for lots of different potential health conditions. Using steroids is for lots of potential health conditions. So it's probably more about the conditions you treat, I would say, rather than the medicine you use. But it is certainly something that I'm not aware of there being an MDO position statement or generic advice. So I would encourage you to seek that individual advice. But do you find that people get similar side effects with medicinal cannabis that they're experiencing from street cannabis? Similar, yes, but often much less of a concern. So with the green market, quite often what's being required can be month to month, week to week, season to season, different amounts of the different ingredients in the treatment. Whereas in the treatment that my patients get, it's cloned from one plant that's been around for 8 years. Each time they pick up their medicine, they know exactly it's the same as what they were taking last bottle or last tub of flour. So there's a real benefit in that, so that any side effect burden that might be present is going to be consistently present, and that really helps us as prescribers to really figure out how to help patients manage those side effects. Good question. Hyperemesis syndrome is much more common with high THC. So if you bump the THC down, you're much less likely to get that. You might have heard of some patients out there saying, oh, well, I've tried the CBD oil and it did nothing. Well, yes, that's true. You need a bit of THC in order to activate the CBD. If you think of, I've had this conversation with patients, if you think about it, it's a bit like a lock and the key. So we've got the receptor, which is in your body, and that's been modulated, and that's the lock, it's not changing, and the medicine we're going to use as a key. But to get the key in and fit it nicely, we need the THC as a bit of sort of lubrication oil to get the key in and get it working. A lot of the work is being done by the CBD, and again, the THC helps, but it has a potentially smaller role. But again, there's many more things in the cannabis than this as well. So again, reminder down the bottom there, cannabis is a drug of dependency potential with addiction tolerance and withdrawal risks. You can mitigate these risks, particularly through careful patient selection. So there's different options. The oral liquid is carried by basically boiled coconut triglycerides. It is probably the most common product out there. If someone says they're using oil, that's usually an oral liquid. Elixir is an ethanol-based high and rapid uptake option, but that is not as common. Sometimes you will see Elixir buccal sprays as well. And the flower, the intact plant, which is really, it's pretty straightforward. It's just picked off the tree, dried, and put into a container. You can see there's some information about when the flower might be helpful. Obviously, we don't want anyone smoking anything, and so the TGA endorses vaporizers out there, which is something I learned. Another question there. I have a fair number of older patients considering cannabis. Any drug interactions to be wary of? Yes, so particularly around anything that might have anticholinergic or sedative risks, which are often things that elderly patients with chronic pain and psychological disturbance are on. So yes, if they do, you can have a cumulative effect of sedation. You can also have a synergistic effect where 1 + 1 = 5. So you have to be very careful for that. The other things to think of are any medicines that might affect alertness or increase the risk of confusion by non-anticholinergic pathways. So they're quite careful. And also things that increase risk of falls. Ones also to think of are any patients that have anti-anginals, long-term anti-anginals. I probably wouldn't be prescribing in that setting because we know that there's a risk of coronary and cerebral artery spasm in cannabis treatment. And so being very careful about patient selection in that group should reduce risks as well. But anyone with unstable angina in the last 6 months, I wouldn't be using it for them. Certainly not with any decent amount of THC in it. High CBD, low THC, potentially that's a much safer way of avoiding side effects because as we'll get into, the lion's share of side effects are from the THC. So there you can see on that slide, hemp oil, cannabis oil. Some people might say they're using hemp oil. Well, that's probably not going to have a lot of therapeutic benefits. Cannabis oil, if they say they're using that, what does that mean? Are they making it themselves? Are they getting it from around the corner of the street? Are they buying it from an internet website and importing it themselves? Lots of different ways that people are obtaining these products nowadays. But if it does have THC in it, then it does need to have either a special access A or B or an authorised prescriber prescription in Australia, or it is breaking the law by having it on your possession. And you can see there on the right-hand side, the CBD, it's not intoxicating. You can have a bit of acute diarrhea with it. I've never seen that in patients even at doses up towards that 1,500 milligram dose. But potential drug interactions, that's in the liver there, the DDIs. Yes, there's quite a lot of those. I won't go into a lot of them, but there can be actions through the cytochrome P450 system as well. So again, these are really important things for you to talk about because you might be having patients on some of these liver-inducing drugs. And they're also then mentioned they've seen a cannabis clinic online and they've started taking this liquid under their tongue at night that they think of this. PDF of this too, please. Yep, I'll forward these slides around and people can have access to these slides. So down the bottom also, history of psychosis, yes, very, very important. THC has an increased risk of psychosis. The antidote though is CBD. So you can get some higher THC or THC only products out there. I'd be very, very, very cautious about using any of those in patients without having a decent amount of CBD on board, usually as part of an oral liquid so that there's a regulation of that long term. So people might have heard of terpenes, and there's a link in the slides there about terpenes. Terpenes are the flavorous aromatic compound that is in the cannabis plants, and the individual per strain, and also through individual plants through breeding. There are probable therapeutic benefits to the terpene profile, but again, these things are only just starting to be measured because there's hundreds of them, and there's often not the ability to individually isolate compounds and use them on their own. So we've talked about cannabidiol, tetrahydrocannabinol, the terpenes, and there's other bioflavonoids as well. There's two main strains, Cannabis Sativa and Cannabis Indica, and depending on who you talk to, they have different views about what the different plants do. But in general, you'll find that each of those options can be found together or by themselves, and there is a big long list on the TGA website if you want to particularly find out what your patients are taking. So if you like to think about treating your own patient, really have a careful think about selection. Think about those that are going to be committed to coming in regularly, because you do need some pretty regular follow-up at the beginning. How are they going at goal setting? How are you aware of what their needs are and their goals? And this is one of the things I think really helps about bringing medicinal cannabis prescribing into traditional general practice. I hear a lot of patients that will see cannabis clinics for just their cannabis treatment, and the cannabis clinicians know not a lot at all about what else is going on with their health. That's not a criticism, it's just an observation of what I've found. Think about those that you'll be able to provide a fair bit of education to, because there's a lot to know in terms of driving, in terms of flying, in terms of patient medicine safe storage, and also just how you interact with the pharmacy as well, because there's a lot of interactions there. You'll need a really good consent process. I've drafted the consent form I use in the practice management software. If anyone wants a copy, I can bring it to them. And that just really goes in explicitly talking about things about if you take it overseas, you might face a death penalty in other jurisdictions. There are significant risks of using this for effective decision making, and therefore any big decisions you need to make around wills, business decisions, financial decisions, then all of these things would be really important not to do while you're using medicinal cannabis therapy. So again, in an elderly age group, that's important to think about when you're trying to mitigate risks. If you don't think that people won't be safe monitoring, then they might not be good choices. There's another question there. If I'm not too keen to prescribe cannabis, what needs to be done? Is there any medico-legal implications of refusing? Look, I wouldn't imagine so. Like any treatment that's outside your scope of practice, you're not obliged to offer it. That would be my thoughts on that. Hopefully you aren't all getting a lot of pressure from patients to become prescribers. I would imagine that would be very awkward, just as it would to be asked to do anything outside of your comfort zone. Communication. So sometimes you're looking at 1 to 2 times a month. The patient needing to go to the pharmacy, they might need to reorder their stock and get it sent days or weeks beforehand. So making sure that the pharmacy knows what's going on. You need to communicate with the patient clearly about this is unregulated, unfunded medicine that for many situations we have a very difficult time about predicting the outcome that's going to occur. And so again, setting goals and setting no-go zones when it comes to symptom burden or progression of conditions important. And also the TGA, obviously, for the authorities and the state medicines regulators. I work in Tassie. Down here in Tasmania, we've got quite an active and quite easy to engage with, I would say, pharmaceutical services branch. And through the TGA SSB pathway, I actually get my patients through much quicker than a lot of the other ones I do from other patients. So that's actually a good thing.
Lachlan, you might get to it, but what are the rules for driving on CBD oil or THC?
Well, on CBD, nothing, because it's not an offence. THC is an offence. Now, I can only talk for the Tasmanian road transport legislation because that's really all I've been experienced with, and I'll do that. There's 2 lines in the statutes that say, one, it's an offence to drive with any detectable THC in the system, whether that was from a week ago or last night or just before you got pulled over. It's an offence. So there's that. Another line says that it is not an offence, quoting the Poisons Act in particular in Tasmania, where if you are driving with a prescription detected in your system of a pharmaceutical, that is not an offence if it's by an authorised medical practitioner. So cannabis sort of falls into this strange grey zone in this area. And these are the exact words I have with patients, and I'll explain to them that they take the risk if they choose to do this. Now, I've had a few people that say, well, I don't drive, or my license has been taken away from repeat drug driving with cannabis anyway, so therefore it's not a problem. And I start to question whether or not this patient's a good patient to have, but, everything's negotiable. And so what I say to patients is, well, if you get tested because you've been involved in an accident or your driving is poor, you're in big trouble, and you just have to accept that. But if you're pulled over and you're asked to do a random drug and alcohol test, you decline the lollipop, the saliva yes or no, black or white evidentiary test, and you ask for the blood test at the lab, which is within your rights. And through that lab level, we'll be able to get a quantification. Then with that quantification, we can make a cogent argument in writing to the magistrate of the court that, well, this is the prescription that we'd expect to have, and this is the amount in the bloodstream we'd expect to have after the dose. Under the Poisons Act, it's not an offence. There is no allegations of poor driving, therefore, magistrate, would you dismiss this case? Now, we haven't had that come to the magistrate here in Tasmania. I understand through discussions that the laws are trying to be aligned so this isn't a problem for patients, but I expect in most jurisdictions around Australia something similar would exist. And if anyone knows through the chat, please pop that into your jurisdiction because that is really important. And often it's the main source of anxiety, Jared, when patients come in is, can I drive? If I can't, what does that mean? And if you're getting people on a daily dose of cannabis, whether it's oral, inhaled, swallowed, assume that they'll test positive to a random drug test at any point when they're driving. Another question there. Are there many pain specialists prescribing this? Sorry, I should laugh because I had a funny situation. So I wrote away to one of the pain specialists of my patient who I'd like to start cannabis therapy on. They've been a long-term patient of this specialist. And I gave the arguments and I quoted some literature and they wrote back, I think with about 3 lines saying, no, there's no evidence that this works in chronic pain. I elect to continue the epilepsy or high dose long term. So there might be some smiles behind the cameras there on some of you. I can't see you all, but I just chuckled to myself and I thought, well, at least there's lots of evidence of using opioids for long-term pain relief. So thank you very much.
Well, Lachlan, your camera's dropped off as well, mate. I don't know if you want to just put it back on.
And those too. Thanks for bringing that up. I didn't notice.
That's right.
Another question, is there a list of prescribers of medicinal cannabis statewide? Not that I'm aware of. Not that I'm aware of. Good question. Maybe there should be. I believe that there's some Facebook users groups and social media groups out there that are pretty active in this space. So that's a good question. The next slide really talks about my, I guess, the 3-visit approach I had, which has really helped me with some structure. And it's up there on the screen, so I won't read through it all. But look, there probably would be 1 or 2 patients out of about 70 odd that I prescribe to on the first visit, but that's often because I've known them very well. But usually it's, here's the information. I want you to go away and have a think about it, discuss with significant others, maybe talk to your health insurance because it is funded under extras. In most health insurances is a non-PBS prescription medication, which can dramatically reduce the cost from sometimes hundreds of dollars a month down to, a cup of coffee a day. Then that second visit's quite important. There's a complete written consent form signed at that point, and then I'll go away and do the TGA Special Access B process, which is what SAS stands for. And then the third visit is, right, we've got all the paperwork in. Now, here's where you go to the pharmacy. Here's how you approach the pharmacy. I do suggest a couple of pharmacies I work with closely, only because I know that it's going to be seamless for the patients. And I declare I don't have ownership in the property of those pharmacies. And then talk about agreed follow-up. And, we're a private billing practice where I work. Patients are very happy to follow this process, I find, in the majority. So we've got something in the chat there as well. For Queensland, is medicinal cannabis recorded on QScript? I don't know. Some of our Queensland colleagues, if they might be able to add to the chat there, that's very interesting. I'm not sure. Don't know much about QScript. So you asked Jared about driving. Well, driving, work and travel, these are really important areas from the regulatory perspective to be aware of. And again, even if you're not the prescriber, just making sure that your patients are aware of these things, because I'm often meeting patients who aren't. State-based Poisons Act will talk about how patients access their medicine, whether it comes via direct mail, whether it comes from a pharmacy, whether they pick it up from the practitioner themselves. And there's another message there. Are you finding patients now seek you out for cannabis prescribing? Well, I've closed my books. So despite that, yes, in Tassie there's not many doing it, but I have had to close my books just out of capacity. Although interestingly, probably 90% of patients that I prescribe for have been like long-term patients. So there are very few that have just come across because they've heard them doing it. So I guess that's something to be cautious of. If you decide to open this up as part of your practice, just be wary that you could have an influx of patients. That could be a good thing, that might not be a good thing, but being aware that, word of mouth travels, people know what's going on quite often, and this is a growing area as we've seen through the statistics. You also need to be aware of the state-based road transport legislation, as I mentioned, and that I don't think will probably be unified at national level anytime soon. Compulsory workforce notifications. I guess I'd be kind of curious, there's some professions, police, the oil and petrochemical industry, I've had to do declarations for because patients said I have to declare this as part of my my employment, and that hasn't affected their employment. They've been able to keep doing their job. They just had to have a form for me filled out. But then there's other, professions as well. That it's just worth thinking about some high-risk professions, medical professions, people who might be involved in significant political and legal decision-making frameworks. Because one of the challenges is that, if someone is impaired, sometimes their ability to detect their impairment impairs before anything else. And so therefore they can lose insight and be unconsciously incompetent, which can be risky, and is a potential risk with cannabis therapy. Another question there in the chat is, there are a lot of companies who advertise their products. Are they interchangeable? Are there some who are better to deal with as prescriber? Really good question. So I only deal with one supplier in Tasmania here. And the only way that I was going to be comfortable I could do this for the patients was I actually met the CEO and the operating officer and had a tour of their facility. Spent a day out there, got to understand their quality assurance processes, and then I was comfortable to start. That was helpful. One, there's no supply chain issues. We haven't got boats crossing the ocean where someone's medicine's stuck. Two, good to support local Tassie industry. Three, get to know the suppliers. What's their new products coming out? What's their back order, wait times, things like that, really helpful. And also, because you don't want to, if you're going to be prescribing, have lots and lots of products that you're prescribing, or it's going to get overwhelming. Yes, a lot of the medicines are interchangeable in terms of the THC and the CBD components. A lot of the formulations out there will be 20-to-1 or 1-to-1 or 1-to-50 or 1-to-4. So there's a lot of consistency around how the products and ratios of CBD and THC exist. What you won't get is the bioflavonoids and the terpene profiles. So that will be quite different. So if someone is sort of changing the medicine from one thing to the other, and it should have the same THC and CBD, but they say it's just different, it's because of the terpenes. And that's a really important part of the treatment, and one we won't go into today because of time, but probably is where the future of a lot of the fine-tuning of this medicine lies. But, I'll go back there. I'd get you to think about whether, doctors should be reporting this in their work agreements, and, what other groups are high risk as well, because it is something that can go wrong. Clear advice and written patient consent forms. I'll just put a plug there for Better Medical's Practice Hub that we've developed. There's a drugs of dependency patient agreement that I sort of port into the practice management software as well. And that's kind of really useful if you've got a patient that really needs to have a read through some of their obligations in terms of not losing their medicine, their script, turning up on time, and being sometimes just organised. Another question there: how long can cannabis be detected in a year in drug screen? Depends on how long you've been using it for, what your metabolism's like, and how much you've been using. But months. You can have hair samples, and the hair samples can be, I believe, up to 18 months, something like that. But you're in up to months, usually a couple of weeks after the last dose, definitely after 4 or 5 days, someone using regularly. Another question there is, are you noticing tolerance and a need for increasing THC? Yes, and that's part of how you prescribe. So, and I might get to that. If I don't, I'll come back to it. And Another question is, so which ratios do you use and why? Very good. I've got some case examples coming up around that. But really what you want to try and do is think about what's the burden and the side effects going to be on this patient. And if you think they'll be all right and tolerate it because they're young, fit and healthy, maybe you want to start with a balanced 1-to-1 product. If you think that they're going to be a bit risky, as it's one of these case examples is, and I think an 86-year-old man, and then we started with an ultra-low dose THC, high CBD product with them. So travel interstate, I say to patients, look, take your approval letters on your and your medicine on your carry-on up the top of the plane, don't put it underneath. Your drug detector dogs at the airports probably will pick you up and you need to display those letters. Don't take it anywhere outside of our national borders. Safety to others, a lockbox is a really useful, safe little tool there that if there's children or others around is helpful, and good relationships with your pharmacy help in lots of different areas. So, assess, discuss, measure. This is sort of a bit of a framework that helps me when I'm thinking about patients. It's not cheap if they haven't got health insurance. And then there's the cost of their attendances as well. Some of these appointments, especially 1 and 2 out of my 3 are long. Sometimes 2 is short, depending on how much you can cover in one, but it could be 2 long or maybe 3 long appointments for them, depending on the circumstances. Another good question there. Any issues with withdrawal? If they're going overseas and can't take it? Look, it depends. Withdrawal is a very unique situation. It will depend on how long they've been on it, how much they're taking, and what their route of administration is. People are much more likely to experience a longer withdrawal if they have been using it for a long time. But interestingly, the length of withdrawal period doesn't change whether you have inhaled or oral or both, but the intensity of that withdrawal can be a bit stronger if you're using inhaled options. Withdrawal usually lasts about a week. And Clonidine and Valium, if anything, would be considered, but usually it's not anything that they need. Getting them to withdraw before they go overseas is a good idea, rather than when they're on the plane. So you really need to determine goals. What are we going to stop? What are we going to regain? What do we want to reduce? And for a lot of people, it's reduce my benzos, reduce my opiates, reduce my pain, improve my sleep, improve my mood, things like that. Think about what the timelines are going to be, how long it's going to take. I say 2 weeks to get a TGA application back. That's probably takes shorter than that, but it takes me sometimes a week to find time to get on the portal to do it. So that's why I talk about 2 weeks. And there's important things to measure there in terms of safety, tolerance, and efficacy as well, which are all pretty straightforward. So if you're not prescribing, how do you look after the treatment of others? And I might just try and whiz through this actually, because I see that we're running out of time. That's all pretty straightforward. Think about emerging medical conditions. This could be something that's not just a side effect, particularly in the elderly and those with polypharmacy. It could just be a medication side effect of another medicine. I would always ask about goal progress. I'm always interested in measuring people's functioning, because functioning is often what they come to you to help with. Adverse effects, we mentioned that. Disorientation, that's important, especially when someone's inducing therapy or changing to a higher dose. THC toxicity, look, interestingly, that is, there are some biological antidotes. So we talked about the terpenes in the plant. There's some other bioflavonoids, linolin, which is in lemon rind, strong one in eucalyptus oil and lavender oil. So if someone's having a bit of a THC overdose event, which is rare, but it can happen, you get them to bite into a lemon while they sniff on some eucalyptus or lavender oil, and they feel a lot better. The TGA SASB, that's the pathway I use. The alternative to the SAS is called an authorised prescriber. Through that, you actually have to submit an application document to the TGA. I'm not bothered with that because I actually get my turnaround faster through the SASB pathway, because the SASB pathway links in with a state-based medicines regulator to give a much more efficient turnaround of the applications, I find. So it's a bit more clunky, but it's overall faster. The the SASA pathway, just for information, that's where you would actually be yourself the importer of the product, and then the patient would obtain it from you. So I wouldn't recommend you do that. It's quite involved. So this is just what the website looks like. It's a pretty easy to navigate dashboard. You click on this here and it gives you your list of patients. You can clone applications. There's no compliance you have to fill out with them. You just register with your APRA number and you just go from there. Really, really easy, somewhat straightforward. One of the things I will bring to your attention is when you're searching for the medicine, you actually in the search need to put CAT, C-A-T, rather than, M for medicinal or C for cannabis. You just put CAT, C-A-T, because it gives you the 5 different categories now that the TGA SNSP pathway uses. So they're, again, relatively straightforward. The balanced one-to-one products will be category 3. Even a lot of your THC dominant products, they rarely get above 98%, so they'll be category 4. And then your CBD dominant is usually category 2. And then, you can have THC only, often in flower, and that will be category 5. The way the TGA actually handles these applications is no different at all. There's no extra criteria or evidence they need. It just helps in terms of the record keeping. Okay, some case examples. So, 56-year-old academic, chronic fibromyalgia, chronic fatigue syndrome, complex childhood trauma, pulsatile alternatives, decades of polypharmacy, including morphine treatment and high-dose morphine. This was really sad to see when I met this person. So they've been one of my longest patients on medicinal cannabis, now 12 months on a dominant oral liquid and balanced flower. And they've stopped their Cabanol, which is fantastic, stopped their Zopiclone, and significantly improved quality of life, and not having to worry with, the green market issues of consistency and legality. So that's been a fantastic turnaround for that person.
So in that first case, Lachlan, would you have started off with a one-to-one to start with, or would you have gone a bit?
Yes.
Yeah.
And this person also was accessing the green market and was quite an experienced user of cannabis themselves. So it was quite kind of useful as one of my first patients who kind of learned together, if you will. I think it's really nice when we learn from patients who learn together. And so that's right. Yeah, very comfortable to start with a reasonably high one-to-one ratio. Questions there, what cost is involved? Private health insurance will cover the costs under extras cover, not hospital, but again, check with the insurance policy, not all of them will. Some are very generous. The next one is an 87-year-old retired military commander who don't have too many of, with severe arthritis of the neck and chronic insomnia. And this was bothering this gentleman and was quite quite a significant burden on his life. So it was fascinating. I just sort of, what have you ever thought about this? And fascinatingly, he said, I think my kids have been pestering me to come and talk about that and get in CBD oil and give it a go. And I'm thinking, well, okay, this person's obviously open to it, and their family might be on board already. So that sort of helps. And someone who's 87, if you can feel like what you're doing from a family perspective is helpful, I think that helps you practice. So we used a CBD dominant low dose oral liquid, slowly titrated up at night. Every night I said, look, use it if it's not sore, because we just need to get you used to it. I think that was around 5 milligrams per 100, 5% THC, so really low dose THC. And I think we started in perhaps out at like 0.2 mils at night, or even maybe 0.1 mil, about as low as you go. And he never got any side effects, and we got him up to, I think, about 2.5 milligrams of THC, so a half of a mil at night. That's all he needs. Another question there is, how do you know how to convert from the green market? You often don't, because the green market is who knows what's going on in their product. You don't know. You could ask someone, is it strong? And they'll often say yes, and what does that mean? And you have no idea. So we know that a lot of the green market THC components can be well upwards of 30%. Usually you won't find anything above 25, 26% in the medicinal market. And often the green market, the illicit market, will be very low in CBD as well, because that's often not why it's grown. And therefore, again, bringing CBD into people quickly is not usually causing a risk. But you might not need as much THC if someone gets more CBD, because they might have been using the THC before in the green market when they didn't need such high THC levels. Another question there: why patient 1 with medicinal cannabis had better outcomes than green market? Well, it stopped them breaking the law every couple of weeks. They thought that was a good outcome. It also had a more regular, again, terpene profile, consistent amount of CBD. They were having to make their own oils, and that was awkward and you know, not easy when they rented in the house. So they were pretty happy to just go and get a little bottle. And I think it actually worked out cheaper as well through health insurance. So there's a few reasons there. And also, it's really hard, as I mentioned earlier, to monitor benefits of treatment when you're not sure what treatment is. Next one's a 41-year-old health professional, severe ME, again, insomnia, chronic pain, inflammatory bowel disease, and moderate generalized anxiety disorder. So each 6 months of balanced oral liquid resulted in improved mood and sleep, reduction in pain, and things got better. Interestingly, too, the gastroenterologist is getting really interested in this, and this patient's IBD improved, probably because of the cannabis. We're not really sure, but nothing else really changed, and would be able to improve their IBD. And return to work and off medicine. So all the goals that we want to see. Next patient was a 45-year-old police officer. Now, this is probably one of the more riskier patients that I ended up treating. Their complex bereavement disorder took a while to diagnose. The alcohol dependency was, you know, at times very, very well controlled, and then at times putting them in hospital. So there were, you know, real issues there. But it seemed to be the alcohol use disorder was as a result of the unstable bereavement disorder. So once we started getting that fixed, then the alcohol use disorder melted away. So we usually get a balanced, again, younger person, oral liquid, and we were able to get them off. I think we went up to like 4s off the phone at night at one stage. It was getting out of control. Improved sleep, and often, you know, this person says now, like, that just it stopped my anxiety. You know, all the therapy and antidepressants in hospitals, all the things in the past. Nothing has actually stopped my anxiety permanently like this, and this is a permanent improvement now being off treatment. Another question there: what's the youngest age patient you would consider using? I don't know. Look, I probably have patients who'd be in their mid to late 30s, and like often that's because cannabis therapy is helpful for chronic conditions. Chronic conditions don't usually emerge in your teens and 20s. You know, they can, but they probably wouldn't be patients I'd be comfortable with, probably because I just don't have enough experience. I don't think I would have a minimum age dose, because again, if someone has capacity and we think it's clinically indicated and most likely to help them, why wouldn't we at least consider it with them? Another question there: are you aware of any palliative care service prescribing cannabis? I'm not. I did have a bit of a chat to a gentleman dying of mesothelioma, chest wall-induced chronic pain. His methadone dose was really high, and he was, you know, sort of not going so well with that. And then they said, again, no evidence, not something they use really. So next example is a 58-year-old man on some government support due to his health for chronic degenerative spinal disease. So he really wanted to use the flower option, and there was no negotiating with other options. And then we, you know, eventually we're able to get the CBD dominant oil for him to try as well. Again, worked really well. This was a patient where they had experience with balms and topicals as well. So again, a very experienced patient. They know their tolerance levels. I was happy to prescribe very high dose flower to them and keep them under really close watch, but again, going really well. Got a bit of time left. So this was an interesting patient. Severe entrenched treatment-resistant social anxiety disorder. Really massive impact on this young person's life. Probably one of the younger patients that has tried it under my care. We used a bit of a as-required balanced oral liquid. They were finding it quite useful when they had a really busy day and had a lot of tense-up energy, and just to complicate things, their partner living at home has dissociative identity disorder, and so one of any 11 personalities any time might just wake them up in the middle of the night and want to play. So that was, awkward for this person. Amongst other things, and so it ended up, we'll continue to use this as an ongoing basis as required, rather than all the time, because they did feel that even at low dose, so 10 milligram of THC per mil, I think they're on about a 0.4, 0.5 mils at night, they still found the next morning they were just a little bit lightheaded and a little bit drowsy, so they didn't want to sort of push the dose, and they were comfortable using it just as required. Again, no withdrawal features at all. What does it cost prescription versus green market? About the same. About the same. There you go. So you're picking my mind. So balanced flower, if someone wanted to sort of say, well, how much might I need to spend? I'd say, well, you're looking at about $120 per month for us to give us a bit of a dose range. It's quite useful, and then they might be able to get a rebate back on that. The dominant flower is about the same. If you look at those costs there, you'll see the CBD dominant oil is quite expensive, which is unfortunate because that's the safer one and the one you might want to use with people with comorbidities, polypharmacy, maybe you're already on opioids and benzos. So there is the higher cost there. Yep, golden rule, starts low, go slow, go very, very slowly. We do want to try and push the dose up or titrate it up over a period of weeks to months. And I often will give on a prescription patients with a starting dose, a window of when they can titrate up, how much they can titrate up, and a ceiling dose. And sometimes with the oral liquid, the oils, I'll say, well, you start with the evening, and if you can, you then bring in a small, maybe 20 to 30% of the total dose in a split form in the morning, so that we can give some biphasic coverage over 24 hours, because the oil doesn't last 24 hours. Little tip there, you can hold it under your tongue, apparently, and it will absorb quicker. So if people are having a long onset with the oil and saying, oh, I wish it was a bit stronger, get them to hold it in their tongue for 30 seconds. Or if that doesn't work, then you swallow some peanut butter afterwards, and that helps as a carrier molecule to bring it into the body. Do you have any patients titrating off? If so, what has been their outcome? Good. Going off is much easier than going on, it seems. Yep, usually just, again, go slow, give them a titration period over about 2 weeks usually, and it usually works fine. Okay, so look, if you're interested to prescribe, be in touch, because networks of practice are really helpful. Jim, who was on the unsuccessful video, and I apologise for that, has been helpful for me, just building a bit of a network, because it's a bit isolating here down in Tassie. Try and team up with your pharmacies as well. Some of your pharmacies might be using a product or a supply that you get to learn about how easy it is to get, what the prices are. A lot of the products listed on the TGA website. I haven't put a link to that, but if you're interested, let me know, or have a look on the website. It lists them all by category. There's 1 to 5 categories as well. So if you want to try and find something, say in category 4, is your patients on something in category 4 where they've run out and they're asking you to prescribe or something like that, it's easy to use those comparators. The drug companies use different names for these things. They're not always intuitive about what's in them, and keep accurate health records. Obviously, very important. If you don't want to prescribe, it's good to be aware of what's going out there, what options your patients have, how they access it. It's accessed like a prescription through a pharmacy. Pharmacy will then order it by using the documentation through the TGA process, and then it's there within the next few days, quite often from the supplier. Define with the patient clear boundaries of treatments. That's really important too. So, I'll often say, well, if you're going to be using this cannabis, this is the only cannabis you're using, and otherwise it doesn't work. Yes, and try and put the medication lists on your practice management software through the customs option. I use best practice. It's pretty straightforward. I can load up a custom preparation in about 30 seconds. Might take others a little bit longer, but the more you do it, the more you get used to it. And then there's some videos there as well. So that, again, some thanks to Jim and his organisation. And down the bottom there, you can see cannabis and chronic complex disease. I think that's about a 40-minute deep dive podcast. So for those that might be really interested in that, that's a good one to look at. And I think we've got a little bit of time there for Q&A.
There's a question down there now from Colin, just about some of the suppliers offer training. Would you recommend any of these, or did you do any of these?
So the initial group that I approached was owned by a pharmacist and promoting their products heavily, and they tried to give me education and teach me the TGA process, and it wasn't great, and so I disengaged. And then I taught myself a lot of these things. There are companies out there now. look, these videos are from a group called Heyday. I've found them really helpful from a collegial perspective, not from a product and marketing perspective. That's just my personal experience. They do run training, others do as well. There's whole conferences now. I got something just through the post, about the medical marijuana conference. I think it's like 4 times this year remotely in Australia, and they're taking your bookings for those. So look, part of it is it's such a nuanced area where there's a fair bit of art going on, and there's a fair bit of research that's still emerging. So I think being aware of that's really important. If you're looking at, or if you want to know, just send me an email. My email's on the screen. If you'd like to know of any groups that are if you'd like my ideas about, if I've heard of them, I'll let you know. If not, I'll let you know as well. But it's definitely an emerging space. I think also for patients, it might be nice for us too if we knew some of these organisations that are prescribing out there that we did trust and we did feel comfortable with, or maybe had a relationship with through their patients. It's nice to say to patients, well, look, I'm not comfortable doing this, but you might, could I refer you to these people? Because personally, I'm not doing that, but I imagine it would be useful for me to have that up my sleeve.
You didn't mention any dose adjustments for like renal function or abnormal LFTs. Is there anything there you need to be wary of?
Not that there's strong evidence around. You might find with impaired renal function that your P450 enzyme system in your liver is not working as well. Therefore, there could be more drug-drug interactions. But in terms of actual organ toxicity and cannabis itself, no. Not aware of any need for dose adjustment. Probably the one thing to think about too in the elderly folk with chronic pain and arthritis is their falls risk. I think that's, always doing a bit of a falls survey of these people coming in, especially on medicinal cannabis. I'll ask them how comfortable they feel getting up at night. How do they feel first thing when they stand in the morning? And are they getting any change in sensation or awareness of where their feet are in space? Sometimes, if you inquire on these people, yes, the subtle things can be in early, maybe that might be an indication to reduce the dose. What are my thoughts on telehealth clinics that are available for us to send patients to? Again, I think like education sources, there'll be different clinics out there offering different levels of support, levels of engagement, level of quality. I guess because I've sort of gone out of my own and done this, it's a bit hard for me to talk about other clinics, but some of them I've written to and I've got excellent letters back about what they're doing with patients. Some of them I've written to and I'm still waiting to get a letter back about what they're doing with patients. So that's my experience. But these are good things for us to share. If anyone finds a top-notch clinic or a clinic that maybe is best to be avoided, if there's a way we can share that within our networks, sensitively and professionally, that's a good use of our networks. I would not presume many countries would allow cannabis. No, correct. So that's on my patient consent form. They always give a smirk when they say, "Oh, I might face the death penalty," because I write it on the consent form just so they remember it. Because we know what happens with boogie board cases, and this is not, this is not something that we would be taking lightly. So we're a bit over time, I think, Jared. But any other questions through the chat, or please take yourself off mute if you would like to have a bit of an answer to the speaker.
Yeah, no, well, Lachlan, thanks so much for your time tonight. It was an excellent presentation. It really gave me a greater awareness of, medicinal cannabis and what its roles are. And it's definitely, an expanding field. You can see by the number of prescriptions that are out there now that, we're going to have more and more patients coming in interested about this. So, you've really opened up my eyes and to, look into it a little bit further.
Well, you're welcome, Jared. Thanks, everyone, for your time tonight. And please reach out if you want any further information. Otherwise, thank you for your attendance and good evening.
Yeah. Thanks, Lachlan.
Bye-bye.
Bye, everyone.